I guess the point to make is that what I'm excited about now, in addition to everything else I'm excited about, is that there is a move to less gene-specific therapy. So more and more companies are trying to develop therapies that will appropriate for all forms of RP.
Welcome back to Don't Harp On with me, Rob Sears. Now, we met Michel Anikina last year, and I wanted to get her back to talk about some stuff to do with genetics. Now, she has got a friend, a colleague. What would you say, Michelle? What's your relationship to Michelle? I've kind of dropped you in there, Jen.
Well, definitely colleague. I'm not sure if friend applies after all the back and forth with my thesis, but
I think
we'll call
after
it
all
that.
these years now, I think we're friends now. Yeah,
We'll
we're
call it
friends.
that.
Yeah.
Excellent. So, friends, we'll call that friends. We're all friends. Great. So, Jen is going to do a really nice introduction to Michelle, and then we're going to get straight into it.
Hello again, everyone, and it's nice to be back with Rob talking about all things RP and genetics. So Michel Michaelides is a professor at the Institute of Ophthalmology, and he works at Moorfields Eye Hospital. I was privileged enough to do a thesis with him on the genetics of RPGR. Which is one of the X-linked RP conditions. And I thought he would be the perfect person to answer the more genetics-themed questions that your viewers posed, Rob. He has got a wealth of expertise and leads on a number of the clinical gene therapy studies that have been active and are active at the Institute. So I will hand over to him and we'll hear what he's got to say.
Great. Thank you very much. So I'll go on a little bit of a discussion about RP, retinitis pigmentosa, a little bit on the genetics, and then we'll maybe spend most of the different treatment avenues that are available. So retinitis pigmentosa RP would be the commonest of the inherited retinal diseases that we see. So there are 300 different genetic causes of inherited retinal disease, and about 100 of those cause RP, retinitis pigmentosa. So the retina being that light-sensitive layer at the back of the eye that detects light, converts that to electrical impulse and passes it to the brain to be interpreted as a vision. It affects about 1 in 2,000 to 1 in 3,000 people, RP, and there are 3 main ways it's inherited. Recessively inherited, dominantly inherited, or X-linked. Dominant form is the commonest form, about 30 to 40%, recessive about 20 to 30%, and X-linked about the rest. X-linked disease primarily affects males because it's on the X chromosome. Females tend to carry the condition but not have much in the way of symptoms, if anything. Rarely they are as severely affected as the males. Whereas in recessive disease and dominant disease, it equally affects both males and females. In terms of severity, X-linked and recessive disease, RP, we're talking about now going forward, it often presents in childhood or early adulthood and progresses more rapidly than the dominant form. Dominant form often will present later and will progress more slowly. When I say rapidly, it's still slow. All forms of RP still will progress slowly and will still be measured on an annual per year basis. But generally speaking, the X-linked form, recessive form present earlier and progress slightly more rapidly than the dominant form. In terms of the how that then manifests in families, we've talked about X-linked. It will be males. It will be passed through the female line, so there'll be a maternal inheritance that will be seen. These will be boys that will present in early childhood, often between 8 and early teens, with difficulty seeing in the dark. That becomes increasingly difficult. Difficulties with side vision, bumping, tripping, often being described as clumsy. And later in life, in late 20s, 30s, having difficulties with central vision, straight ahead vision, recognizing detail, faces, colors, and eventually profoundly reduced vision in their 40s. That sequence of events does occur for all forms of RP. Recessive can be just as I've described for X-linked, but sometimes is later. Dominant form, as we've said, often more commonly is picked up in adulthood. The exceptions are where there's a well-known family history, because dominantly inherited disease is there's a situation where if you have dominant RP, you have a 50% chance of passing it on to a family member. So usually with dominant RP, there's a family history of males and females having the disease in the same generation or prior generations. There's usually multiple generations of people with RP, and it's passed by males to males or females and females or vice versa. There's no predilection to any particular pattern of male to female transmission or vice versa.
On that point, Michel, one of the questions was asking about if the family has an autosomal dominant RP and one of the children does not have the disease, can they still carry it?
Yeah, no, absolutely. So you can have no symptoms at all, even have normal retinal photographs, imaging, assessments of the architecture of the retina can be normal, but yet you do carry the genetic cause. You do carry that genetic variant, spelling mistake, fault, all means the same thing. And it's very typical within families with dominant RP that there is tremendous variability, ranging from, as you've said, not having any symptoms at all or ever being affected with RP throughout your life, all the way through to having symptoms in childhood. So it's incredibly variable. You can't predict the nature of your experience of the disease from your parents or your siblings. So tremendous variation within families, but also between families. So even families that carry the same, even specific change in the same gene can have a very different experience. We think that's primarily due to the genetics, given that, we're all unique. You would have thought there'd be several, well, maybe hundreds of Jens or Mikes or Robs, but there aren't. There's only one, which is quite staggering, really, given 7 billion people and over the course of humanity, how many billions of people. So the genetics make us very, very unique, because there's tremendous variation in the approximately 20,000 genes that we have and all the intervening genetic material in between all those 20,000 genes. Now, of course, there's always that question of nature nurture, and as in, does the environment, does your exposures affect things? And I'm sure there are environmental factors which are very little understood. In fact, the genetic variation, how changes in other genes affect a particular condition, is poorly understood. But I think it's primarily the genetic variation that results in this difference. And recessive, going now back to inheritance. So recessive RP is where parents will be carriers for RP. So they'll have the potential to pass it on, but won't have RP themselves. So we're all carriers for approximately 10 to 12 different conditions. And it's just a matter of chance whether our partner is a carrier for one of the same 12 or so conditions, when it could be one of several tens of thousands. And eventually, again, going back to how many people are around, eventually 2 carriers come together and they have affected children. But that's rare, but it happens, 1 in 3,000, something like that. And in that situation where those parents are carriers, but don't have RP themselves or any symptoms, it's a 1 in 4 chance that any of their children will have the condition. And it's a 1 in 4 for every single child, every single pregnancy. It doesn't matter if you've had 10 unaffected children, 10 affected, every single time, 1 in 4, 1 in 4, 1 in 4, 1 in 4. Most of RP is an isolated condition. It only affects your eyes. You only have retinitis pigmentosa. You only have this progressive retinal condition. Only what I mean, not to minimize the condition, which is very challenging, I mean that there's no other health issues. You don't have any other problems otherwise. They're otherwise healthy. In a minority of cases, there are other problems around the body, and by far the commonest other condition you can have is hearing impairment. So the commonest cause of people having hearing impairment and visual impairment, and usually RP, would be Usher syndrome. But as I say, primarily it's just affecting your eyes.
That's exactly right. And I mean, Rob, obviously our mutual acquaintance as well. I mean, she's got an Usher, I believe, an Usher gene. Although bizarrely, which was sort of a news to me as well, is that her hearing's not impaired. But it was the same gene that's implicated in Usher's. That's the issue there. But that's just the example of what you were saying, Michelle, about the variability, presentation of the condition.
Yeah, absolutely. It's a perfect example of that, and it just shows how complicated genetics is, because there's one particular gene called USH2A. That's what it's called. The gene is actually called USH2A. And that gene is the commonest cause of recessive RP, okay, that isolated RP where your parents are carriers, as well as the commonest cause of Usher syndrome type 2, which is the commonest cause of Usher syndrome, so thereby the commonest cause of having RP and hearing impairment from birth. It's thought that you end up having more severe changes within the Usher's 2A gene, which results in you having ear and eye problems. And if you have milder changes in the gene, you have isolated eye problems. It doesn't always work quite like that, but that's roughly what's thought to happen. So that's absolutely right. And actually for the X-linked forms of RP, occasionally patients will suffer with issues such as sinus problems or breathing problems from bronchiectasis, bronchiolitis, and occasionally there are fertility issues because, again, the link there with all those different things is these little fine hairs that can sit on cells called cilia that are useful for motility and other aspects. So again, can also affect hearing because those are also important for hearing.
Yeah. Now, there were several questions that came in as well, looking at the sort of the registries, for the genetic registries, and the studies that are in place. So are there any database or registries for patients with RP in the UK? I think you can definitely answer that.
Yeah, no, and it's very important for us all, for patients to be aware of registries and to try and get on to those registries and support those registries. So the largest at the moment is actually at Moorfields Eye Hospital. Genetic database of patients with RP or related conditions is within Moorfields. It's been accrued over the last sort of 3 decades. Many other specialist centres, including in Manchester, in Leeds, in Oxford, in Southampton, will also have their own databases. There's been discussion, partly driven through charities such as Retina UK and others, to try and establish a uniform, a single UK repository registry. That hasn't as yet happened. I think that would be a good thing. In terms of from patients' point of view, I think it's helpful for them to be seen at least once in one of these specialist centres. I think there's value in that, to touch base with subspecialists who sort of look after patients with RP on a day-to-day basis, ensure that they get themselves onto those databases, and also to ensure they access genetic testing. So the key aspect of these databases is not only to be on there saying I have RP and it's presumed to be recessive or dominant or X-linked or uncertain, is that there's an associated genetic diagnosis to confirm the way it's inherited, and within that inheritance, which specific gene is it that's causing my recessive or dominant or X-linked RP. And we can find that in about 60 to 70% of patients, which isn't 100, and we all want more, it's human nature, but 60 to 70% is actually really very impressive in terms of genetic disease affecting human beings. And the testing available through the NHS for free, is very comprehensive, very robust, a huge panel of genes, ever-changing numbers of genes that are assessed. But 60 to 70% of patients can have a specific genetic diagnosis. And that's powerful because it's helpful for people to understand how their RP is inherited and what those implications may be for themselves and other generations and their children. And also there's potentially the ability to provide more accurate, better informed advice on prognosis based upon the specific genetic diagnosis. There are also gene-specific therapies that are being developed. And so people talk about gene therapy, and most of the time when they talk about gene therapy currently, they're talking about recessive or X-linked disease, where in the main, the cause of RP is that the genetic change results in a deficiency, a lack of something being made in the retina, often the light-sensitive cells, the cones and the rods, the photoreceptors. And that deficiency can be addressed by putting a normal copy of the gene into those photoreceptors to encourage them to make what's missing and hopefully restore their function and keep them healthy structurally.
Yeah.
Of course,
I know you've been very keen on getting this sort of very specific genetic diagnosis for all the patients on the registry, because of course that does lead into the gene therapy. So now it's time to summarize all of the the opportunities in the UK in the past and in the future, I think.
Yeah. So access genetic testing if you haven't. You should demand that it's available for free. In terms of the gene therapy trials for RP that are happening, recruiting in the UK or happening globally, and in many ways, yes, it's great to take part in or consider taking part in a study in the UK, but what's more important is that they're happening. Whether they're recruiting in the UK or not is irrelevant to a certain extent, in the sense that we want these studies to be happening, to be identifying potential treatments. The most advanced is for the commonest cause of X-linked RP. That gene is called R. There is a phase 3 trial, so that's the final clinical trial that needs to be done prior to potentially having a drug approved. That has been completed by a sponsor, two sponsors two companies called Mira GTX and Janssen Pharmaceuticals, Janssen being part of Johnson & Johnson. So that trial is completed, and the data from that trial we expect to be released anytime in the next couple of months. It should be the first quarter of this year. If that is successful, if that phase 3 trial was successful, they will rapidly be looking to get their drug approved in the UK, so speak to the MHRA. In the US, speaking to the FDA. In Europe, speaking to the EMA, and then beyond. What are the timelines? About a year. If it's not successful, then that may be the end of that therapy. If it's somewhere in between, I suspect that they will still be having those discussions with the regulators, the FDA, MHRA, EMA, to have those discussions about the fact that this is the first potential therapy for X-linked RP. And as a first therapy, there's sometimes a little bit more flexibility that regulators will apply. There is another phase 3 trial for X-linked RP, caused by RPGR, that the sponsor is called Beacon Therapeutics. That is currently recruiting for phase 3. It is recruiting in the UK as well. I believe they're about 6 months away from finishing recruitment. And then it would be a year after that to potentially be in the same situation I've just described for Mira GTX Janssen. So I guess about a year behind, so to speak. Optimistic about both, of course. I'd like to hope at least one of those two would be successful, if not both. And that would be available then to adults, children, affected female carriers. In terms of other genetic therapies for RP, there are other trials that will be commencing in the UK. Those will be for a particular USH2A genetic variant, so particular change in USH2A. We've touched upon USH2A as the commonest cause of recessive RP and the commonest cause of Usher syndrome. That will be recruiting soon. That's being run by a sponsor called Sepal Bio. In terms of other forms of RP that are looking promising, there are childhood onset forms of RP. Sometimes they're called childhood onset forms of RP, or they're called LCA, Leber congenital amaurosis. So one is for AIPL1, another gene. Incredibly severe. These children are born with perception of light. They can barely see light, so effectively blind from birth. The genetic medicine treatment has been staggeringly effective. All 11 children can now see. They can now read on the chart. And so that's been sponsored by Mira GTX. They're speaking with MHRA to get that approved and have started discussions with the FDA and EMA. Other LCA forms are in gene therapy currently, including LCA5. That's in trial. In terms of dominant RP, so dominant diseases are harder to treat genetically, and so they haven't got into trial as yet. There are some that are being considered, and I think they'll start in the US, but haven't started as yet. In terms of other genetic therapies for RP that are being considered, I'll just reel off a couple of genes in case there happen to be genes that people who listen to your channel have. So PD6A, PD6B, RLBP1 are some of the ones that are looking to be treatments to be reinitiated soon. And there's a raft of other LCAs as well that treatment is likely to start in the near future. In terms of other types, maybe just briefly, I'll touch on a couple of other modes of treatment. So there are drug trials that are very advanced. So there is a phase 3 trial for RP, any form of RP. It's gene agnostic. You do not need to have a genetic diagnosis. We do not need to know the gene. We just need to know that you have RP. That's called the N-acetylcysteine drug trial. It's partly by the NIH in the US, so the American Department of Health, if you like. That's a multi-center international trial throughout the US, throughout Europe, including Moorfields. We're recruiting patients with RP. You need to have early to moderate stage RP to take part in that. In about 18 months or so, we'll know if it works. If it worked, again, that will get rapidly approved because it's a drug that will be very cheap and readily available, and that will be wonderful because it's not gene specific. Its aim is to slow progression and would be thereby helpful to all forms of RP, which reminds me, for gene therapy, we didn't really mention that the primary ambition would be, again, to slow degeneration. However, we do more often than not see improvements in aspects of vision, which we wouldn't necessarily expect with a drug therapy. Again, just briefly, I'll touch on late stage RP. So for late stage, different types of treatment are likely to be helpful. That being said, I think the most promising currently is a genetic medicine, a type of genetic medicine at least, called optogenetics. So that's, again, using viruses to deliver genetic material, but that's rather than to the photoreceptors, the cells that are primarily affected in RP, this sort of stage of disease where those have all been lost. There are no photoreceptors now, but still the inner portion of the retina, the part of the retina that conveys the information from the photoreceptors to the nerve, to the brain, remains intact. And so the aim of optogenetics is to make those cells, rather than just conveying information, to actually detect light in their own right, convert light to electricity, and thereby to restore a degree of vision. Now, there's some very sensitive pigments that have now been developed to make those cells light sensitive and to respond in normal ambient lighting and to be very rapidly responsive. Their kinetics is really appropriate. And I'm very excited about that. There are several sponsors. The most advanced is Nanoscope. They're getting into phase 3. We're hoping to be a site for the phase 3 in London at Moorfields. There'll be other sites throughout the world. There are 2 other sponsors I'm aware of, again, are very advanced, look very exciting technologies, Ray Therapeutics and Restore Vision. The first 2 are US, the last one is Japanese.
That is very exciting, Michelle. I was gonna actually mention that because we talked about it with you before, and it's essentially taking a cell type and just changing the function of it, isn't it? Just changing completely what it does. They're not actually introducing anything new into the retina. So it's not quite what stem cells do, but it's sort of trying to do the same thing because, of course, in late stage you haven't got any cells to work with to change the DNA off to make them work, and that's why you're having to sort of think of other strategies.
Exactly right. So you're trying to exploit the natural network of cells that remain, and you might still be able to get some processing within the retina depending on which of those cell types you target. And that's why I'm particularly excited by it. But not only about the technology per se, there is data out of Nanoscope that has shown patients can actually see significantly better, almost better than you would have expected. So that's why I think it holds promise for the future. Now, you touched upon the others. So the other ways of trying to improve vision would be to try and replace those cells that have been lost with new cells. And that is, as you say, the remit of stem cell therapy, cellular therapies. There aren't any trials yet to introduce new photoreceptors. They're getting ever closer. There are groups in the UK, in the US, and Japan. They're getting very close. But I still think it may well be a couple of years away. I'm sure it will be successful, but I think it could well be 8 to 10 years away. The third way is to actually introduce an artificial means of detecting light. So that's a microchip, a retinal implant with lots of little pixels that can detect light, again, convert those into that light into electrical impulse. And those can be placed on top of the retina or put under the retina by people such as Jen. So it's very challenging surgery. There was one particular implant that was approved. It did have a CE marking and the equivalent US marking. It was unpredictable which patients would benefit. And unfortunately, it wasn't as durable as one had hoped. So they've had to be removed from the eyes. And so they no longer are made. There are other companies trying to make better biocompatible materials and implants. The nanotechnology, the ability to miniaturize things has improved over time. These are going to be better chips, higher resolution. So I think that's also potentially promising. And finally, kind of several decades away, but no longer sort of in the realm of science fiction, a whole eye transplants. So there are groups in the US and actually in India as well, trying whole eye transplants. And there's actually just been a new sort of initiative by the NIH, as we mentioned earlier, the Department of Health in the US, putting out a challenge and a fund to try and encourage people to look into whole eye transplantation further. So, loads going on, lots of optimism across the entire gamut of severity, early to late. So I remain optimistic that increasingly there'll be therapies available. And we haven't touched upon, of course, what is already super helpful and increasingly will be helpful and change all of our lives is of course technology in its own right.
Yeah.
I assume we won't be driving or doing anything, it'll be all automated. We might not even have any jobs to do.
We might be out of a job in a few years.
Might be, yeah.
But yeah, the whole eye transplants, it's fascinating, isn't it? Of course, we probably can transplant an eye and make it stay alive and sit there there and look like an eye, but the challenge is, of course, getting the nerves to join up and to talk to each other, which we haven't sort of quite cracked as yet, but there's lots of work ongoing with that. I think that's a brilliant summary. I think there's a lots of news there for me as well. Rob, what do you think?
Well, it's really interesting. I mean, I love the fact I was just stepping back and watching you two go. And to see and hear how excited you were about particular things is really nice for me. I think the thing that I really have found useful for myself from this conversation is that as an RP sufferer, when you're in groups, you just get little snippets of information, or this is coming, this is coming, this is coming, but there's never any like science or understanding behind it really. So you get sort of these trials are happening, this is going on, this is happening. So to actually get a little bit of understanding about, you know, what stage it's at, what that means, how far in the future we're looking and stuff, it is really optimistic and really exciting. And yeah, I mean, I can't thank you both enough for the time you've put aside today and the expertise and knowledge that you have. And I feel like I've greatly developed as an RP sufferer just from listening to you two today. So yeah, I just blown away really. Thank you so much.
Pleasure, Rob. I think the key question, the last one we haven't addressed is, Michel, how soon will there be a definitive treatment for RP?
I wasn't going to ask that. I thought, no, I'm not going to ask that.
Sure, yeah, the multi-billion-dollar question. You know, I guess the point to make is that what I'm excited about now, in addition to everything else I'm excited about, is that there is a move to less gene-specific therapy. So more and more companies are trying to develop therapies that will appropriate for all forms of RP rather than individual forms. So if it were individual forms, we would need 100 approved therapies. Now, that's not inconceivable, but it's obviously very, very challenging. So some of these general therapies, there are drugs, there are genetic, there are neuroprotective type agents that are looking promising. So I think those are going to be put in place. In terms of what's the next thing that's going to be approved and available, RPGR, X-linked RP will be the next approved. I really, really hope they both are approved, or at least at least one of the two.
There we go.
We look forward to that.
Put him on the spot, and then that's it. That's the delivery. I think we covered last time somebody saying about eye transplants, and that it sort of fascinates me and creeps me out a little bit in the same, you know, the same kind of, yeah. I'm kind of tongue-tied. It blows my mind that these things are actually being thought of and trialed, and yeah, it's really cool. Oh, well, that was big. That was
big and clever. Thanks so much.
Great, no, great pleasure. I hope it's useful. I hope your gang like it, and I'm sure we could do something else if it's helpful in the future.
Yeah, I mean, even if it's just for me personally, I think that's a great idea. So yeah, absolutely. Michel, Jen, thank you both so much.
Great pleasure.
Yeah, I can't say any more than that, can I really? So.
Right, guys, thanks so much. It's a real pleasure. Take care.